ॐ सहना भवतु सहनो भुनक्तु सह वीर्यं कर्वावहै तेजस्विनावदितमस्तु मा विद्विषावहै। ॐ शान्ति शान्ति शान्तिः। Dear students, we are today continuing our lecture series on fracture neck femur. We are going to focus more on the complications of fracture neck femur today. So the first complication here is the thromboembolism. Thromboembolism is a leading cause of death within first 7 days. The incidence is as high as 40%. The second important complication is the non-union. Only 1/3 of the fracture neck femur are known to heal with open reduction and internal fixation. The non-union rate is almost 85 to 95%. If there is no evidence of radiological healing taking place within 6 to 12 months of the treatment on a radiograph, it is declared as a non-union. The causes of non-union includes the inaccurate reduction, poor internal fixation, lack of cambium layer in the periosteum of the neck, avascularity of the femoral head, and posterior wall comminution. These are the 5 important causes of the non-union in femoral leg fractures. Coming to the clinical features, the patient is unable to bear weight on the affected site and the Trendelenburg test or telescopic test will be positive. Wasting of the muscles and minimal shortening of the affected lower limb are the other features. Radiographs of the hip reveal ununited fracture neck of the femur, and there may be a avascular change in the head. The treatment is concerned. The treatment for the non-union, surgery is the treatment of choice. The method chosen takes into account the viability of the head. Now, if the heads are viable, then osteotomy is done. McMurray's displacement osteotomy, as shown in this particular diagram, or the Shanz angulation osteotomy as shown in this particular diagram along with the bone grafting is done. McMurray's displacement osteotomy, in this the osteotomy is made just proximal to the lesser trochanter. Just look in this particular diagram, and the distal fragment is pushed medially and then it is fixed internally. Whereas in the Shanz angular osteotomy, in this particular osteotomy is made through or just distal to the lesser trochanter, and a laterally based wedge of the bone is removed and the varus angulation is corrected and then fixed with the plate and screws. The role of osteotomy, the displacement or angulation osteotomy helps to convert the shearing forces at the fracture site into compression forces by changing the line of weight bearing, and thereby enhances the chances of fracture union. Now, among the two, angulation osteotomy is preferable because the position of the greater trochanter is more satisfactory after this particular surgery. The function of the abductor muscle is reestablished more effectively. There is no further shortening as well, and the internal fixation is maintained more satisfactorily. That is why the angulation type of osteotomy is preferred nowadays. Now, the osteotomy is a treatment of choice for a non-union fracture neck femur, has a role only if the head of the femur is viable. Otherwise, hemiarthroplasty is preferable. As mentioned earlier in my last video, if the head is not viable, but the acetabular cartilage is viable, and if the patient is over 60 years of the age, then hemireplacement arthroplasty is the treatment of choice. However, the choice of prosthesis depends upon the existing calcar femoris. Now, as shown in the diagram with the red dot, if sufficiently calcar femoris is present, at least 1 to 3 centimeter in size, osteotomy prosthesis is the choice. And if it is inadequate, as shown in the third diagram shown by the red dot, Thompson's prosthesis is preferred. Now you can differentiate between two prostheses. In osteotomy prosthesis, the fenestrations are seen. In Thompson's prosthesis, there are no fenestration in the stem. Bipolar hip replacement is another option. Again, is indicated here in the second diagram with the red dot. Total hip replacement, if both the femoral head and the acetabular cartilage is not viable, and if the patient is more than 60 years old, the total hip replacement is the surgery of choice. Now it is the next important complication, avascular necrosis. So avascular necrosis is the next important complication, and two types are described. One, it is due to the actual avascular necrosis, and this is secondary to the ischemia and is an early phenomenon. It shows characteristic macroscopic appearance, and the second variety is the late segmental collapse. Now it is due to the collapse of subchondral or the articular cartilage that overlies the infarcted bone. So it will occur late. The AVN incidences in the displaced femoral neck fractures, the femoral head survival is dependent on the vessels of ligamentum teres, which is absent in almost 1/3 of the cases, and the subfoveal arterial anastomosis, which is variable and incomplete. Now all vessels within the femoral neck and most of the retinacular vessels are disrupted in the displaced fracture, and hence the survival of head depends on uninjured vascular supply and second, revascularization. Now the vascular injury occurs at the time of fracture, which is very common, and secondly during the reduction or internal fixation, and hence the good anatomical reduction and stable internal fixation is required to preserve the remaining blood supply, which helps in revascularization. Investigation wise, the radiograph shows increased density of the femoral head, and this may take 6 months to 2 years to be seen on the radiograph. Now bone scans, they can early and accurate determination of avascularity can be made using the bone scan, but it is not 100% accurate. The treatment wise, the symptomatic treatment like the bed rest, non-steroidal anti-inflammatory drugs, NSAIDs, etc. And then the displacement or the angulation osteotomy in the early stages. And if the articular cartilage is viable, hemireplacement prosthesis is also preferred. And if sometimes the total hip replacement if the acetabular cartilage is not viable. This is what we have already seen. Now coming to the next topic of discussion today. The next topic of discussion today is the trochanteric fractures. We call it as intertrochanteric fractures as well. The salient features being an intertrochanteric fracture occurs along a line between the greater trochanter and a lesser trochanter with variable comminution. It is totally extracapsular. Internal rotators of the hip remains attached to the distal fragment, and short external rotators are attached to the proximal head and the neck. And hence the limb has to be kept in an external rotation after reduction to align the distal fragment with the proximal one. The cancellous bone heals well within 8 to 12 weeks. Now it is 4 times more common than the intercapsular fractures. The age seen in the elderly patient is 10 to 12 years older than the intercapsular fracture neck femur. Sex, it is more common in females. The ratio is 2.8 females to 1 male. Coming to the mechanism of intertrochanteric fractures, direct trauma as in RTA, road traffic accidents, fall, etc. And indirect trauma may be due to the muscle pull, etc. It can be the mechanism for the intertrochanteric fractures. The clinical features, the patient will have pain, marked shortening of the lower limb, and complete external rotation deformity. Now look in the second picture. There is a gross shortening of the limb, as well as there is a complete external rotation, the lateral border of the foot touching to the bed. Then there will be swelling, ecchymosis and tenderness over the greater trochanter. Investigation wise, the radiographs have to be done a true anteroposterior view in internal rotation. Why internal rotation? To look at the profile view of the neck of the femur. So a true anteroposterior view in an internal rotation and a lateral view helps to study the fracture pattern. Now this lateral view is usually done by not moving the injured limb. You can very easily take it by taking a cross table view. You can abduct the uninjured limb completely, and then the X-ray picture tube can be inserted in between the two legs. The cassette can be kept above the iliac bone, and a cross table lateral view can be taken. Treatment wise, the trochanteric fracture treatment includes the conservative treatment. Now there is 10% mortality associated with conservative treatment that we must always understand. Now the indications for the conservative treatment includes the poor medical and surgical risk of the patient, terminally ill patient, and a very old patient. And method would be simple support with the pillows or the box traction or the plaster spica and the skeletal traction through the distal femur or tibia for 10 to 12 weeks. However, the surgical treatment is the method of choice. Though not an emergency, there is an urgent need for surgery, as there is a 10-fold increase in mortality if surgery is delayed for more than 48 hours. Advantages of surgery includes increased comfort, good nursing care, and hospitalization stay is considerably reduced. Goal is to fix a stably reduced fracture internally. Now methods of reduction. The close reduction is by traction, slight abduction, and external rotation. If reduction is not obtained, then open reduction is also done. The indications for surgery being the failed close reduction, open reduction being the failed close reduction, the largest spike on the proximal fragment with the laser trochanter intact. Most of the time it prevents the close reduction. And then reverse oblique fractures. The choice of implants include once the stable reduction has been obtained either anatomically or by any one of the non-anatomical methods, the implants are chosen as shown from the above diagram. Now the first diagram shows the DHS. For stable fracture, the choice of implant does not matter. For unstable fracture, sliding hip screw DHS is the most suitable, and 135 to 150 degree angle side plates are most commonly used. The placement of DHS screw in the neck should be either in the central or posterior inferior. The dynamic hip screw allows to secure fixation of the fracture and permits controlled impaction at the fracture site, thereby reducing the risk of fixation failure seen with the rigid nail plate like SP nail plate etc. Now, as shown in the second picture with the red dot, the PFN, proximal femoral nail, is being preferred nowadays over DHS. The advantages of PFN being it can be inserted quickly. There is a less blood loss in the surgery. Early ambulation can be done. Sliding and the limb shortening is less as compared to DHS. It is more successful in reverse oblique fractures. The features of PFN includes the standard length is 24 centimeter as shown in the first picture. The long PFN is also available more than 36 centimeters in length for the low subtrochanteric fractures and for two-level fractures. The proximal wide portion, as you can see in this particular diagram here, a long screw and the hip pin can pass through the head and neck. Distal part has got a dynamic locking hole and a static locking hole. Now there are certain problems with the use of PFN. The first thing is entry point has to be chosen very carefully, preferably in the piriformis fossa as shown in the second picture. Excessively curved femur is a contraindication. Second is postoperatively, if you are using a short PFN, then the thigh pain is seen at the distal tip. And it cannot be used if the fracture line extends into the piriformis fossa, and here the DSS or the condylar blade plate is better. Coming to the comparison of the intracapsular fracture and the IC fracture neck femur. If we see the age, the IC fracture neck femur occurs in elderly patients, whereas in IT fractures, the patients are more elderly. The incidence wise, IC fracture is a common, but IT fracture, that is intertrochanteric fracture, is 4 times more common. Blood loss, it is less in intracapsular fracture, it is more in IT fracture. Shortening is minimum in intracapsular fracture, whereas shortening is gross in intertrochanteric fractures. Deformity, in intracapsular fracture, minimum external rotation is seen, whereas in intertrochanteric fracture, there is a gross external rotation. Now tenderness clinically, in intracapsular fracture, the tenderness will be seen at the anterior hip joint line, whereas in IT fracture, the tenderness is on the greater trochanter. Conservative treatment is not successful in intracapsular fracture, but in IT fracture, it can be successful. Surgery, absolute indicated in intracapsular fracture, but in IT fracture, it is indicated for early mobilization only. Non-union is very common in the intracapsular fracture, and it is rare, less than 1% in intertrochanteric fracture. Whereas malunion is unheard in intracapsular fracture, but it is very common in intertrochanteric fracture. The intertrochanteric fracture often malunites in coxa vara. So coming to the complication, due to the cancellous nature of the bone, these fractures unite well, unlike the fractures of the neck of the femur, but malunion is quite common. Coxa vara and non-union is less than 2%. It is very rare, and the traumatic osteoarthritis is also seen. This X-ray is showing the infected implant. Look at the second picture. The translucent zone around the implant is seen. That is suggestive of a layer of granulation tissue over the infected implant. Now these fractures also carry a higher incidence of mortality, more than 10%. Avascular necrosis is very rare, 0.8%. With this, we finish our discussion on IT fracture. Now before we end, I want to talk to you about one more important topic, happy key to lose weight. Dear students, one of the commonest problems we are facing in our routine clinical practice is of obesity. Eat less and exercise more formula for treating obesity has been proved to be the failed formula. Of late, I have been working on the latest, most scientific, evidence-based concept of weight loss, that is the happy key. Now you may find few videos on this topic as well on my YouTube channel. The obesity among the medical students is at its peak nowadays. Due to obesity, not only they are bullied, but most of them also lose their self-confidence, resulting in deteriorating performances in the academics. For all of them, this online video course will be most valuable. If interested, you may visit my Facebook page, on the Happy Key and website www.drorthosudhir.com. For details of this course, I recommend you all to watch my above mentioned video completely. That video is on YouTube, how to stay slim and healthy forever without dieting and exercising. You may forward that video to others as well. The YouTube link is given in your screen. You can use that link. My mission is to help more than 10 lakh persons to lose weight and get lifetime freedom from obesity without dieting and exercises using this Happy Key technique. Let us all come together to create a healthy and fit India. Please like my channel, subscribe it now, and do recommend it to all your colleagues from other medical colleges as well. Please help me to help medical students all over the country. Your recommendation matters a lot for me. Thank you. Thank you for your subscription, like and recommendation for my channel.